Patrick. Hi, everyone. It's great to welcome you again to the February iteration of our Catalyze seminar series. Today, you'll gain a deeper understanding of health economics research informing reimbursement and what that means for you as a medical technology innovator. Our presenter today is Dr. Renée Arnold, an entrepreneur in residence at the National Heart, Lung, and Blood Institute of the NIH. She is also currently the president and CEO of Arnold Consultancy and Technology, where she develops and oversees outcomes research and affiliated software for pharmaceutical companies and the federal government. So with that, Renée, I am so excited to welcome your presentation.
Thanks a lot, Marissa. So for NHLBI, my area of expertise is health economics and outcomes research in support of reimbursement. Reimbursement isn't my primary raison d'etre, but I do a lot in support of reimbursement, and I think I can give you a very good overview of what you can expect during the reimbursement activities in which you'll be engaging. The objectives here are, and this might seem anathema to what I was talking about before, but give you a basic understanding of the structure of the US healthcare system. It's quite fragmented. We don't have a nationalized health service, as you know. And because of that, you have components of reimbursement in every category. So I thought I'd give you a quick overview and you can understand, hopefully, where reimbursement is coming from in each of the sectors. Medicare, Medicaid, and the private sector, the commercial sector. And I'll be interspersing a lot of that with evidence development and how that supports reimbursement. So health economics and outcomes research, known as HEOR, again, is used in support of reimbursement. How much does an episode of care cost? Why do we care about how much an episode of care costs? The first thing we normally do when we're hopefully a technology that is supporting a disease or condition, rather than a disease or condition in looking for technology, is to determine unmet need. Unmet need has actually come into the general vernacular these days. Everybody has an unmet need, but in terms of HEOR and reimbursement, unmet need really means that the disease or condition is not being adequately controlled, that the patient has a poor quality of life or less than adequate quality of life. It's a very costly disease to the healthcare system, and we have to measure that. What is the unmet need? Why should you develop this technology? And what impact will it have on the unmet need for this disease or condition? There are several different ways that we determine unmet need. If you're lucky, somebody's done it for you and they've written it up in the literature, published literature. So you can look and see, okay, people decided that asthma is very costly and it costs the US healthcare system X amount of dollars per year. Maybe you even have OUS information, so outside of the United States. And you can demonstrate that it's very costly outside. There are a lot of uncontrolled patients. They end up in the ER and hospital, et cetera. And when I talk about episode of care, we're not just talking about one acute day in the life of a patient. An episode of care for asthma, for example, maybe an asthma exacerbation, may be that the patient starts having problems breathing. They end up, well, we can talk about COVID. They end up in the ER. Maybe they're admitted. Then they're maybe in the ICU, unfortunately. So you've got several different places that they may end up in the hospital. Ultimately, hopefully they're discharged, okay, but the episode of care doesn't end there. You've got outpatient follow-up visits. You've got maybe rehab. You've got any number of things going on. So the episode of care is really the entire trajectory of what is going on with that patient with that illness. Will your product, will your technology have an impact on that episode of care, hopefully a positive impact, and how will you quantify that impact? Can you demonstrate improved health outcomes, so improved quality of life, reduced resource use, such as unexpected clinic visits, again, ER visits, hospital days, medication. You might paradoxically not have a reduction in medication cost, because an increase in medication cost may mean that you have a reduction in other more expensive resources ultimately. If you expect that your technology will improve quality of life, some people are surprised to hear that the FDA grants indications for quality of life, especially in chemotherapy. So if you expect that your technology is going to improve patients' quality of life, you may want to use an FDA-sanctioned survey instrument when you're doing your studies. It's really important to think about all of these things, health economic endpoints. Do you expect that you will actually be able to avoid costs and infer cost savings, or will your technology be cost effective? We talked about quality of life already. And if you expect to pursue reimbursement outside of the US, you want to be particularly interested in cost effectiveness, because most countries, and even in the States, with developments in this group called the ICER, ICER, they are requiring cost effectiveness analysis and cost effectiveness modeling. So you have to start thinking about that as you're planning clinical trials. You don't want to happen what sometimes happens with some of my clients when they come to me and say, oh, we've got KOLs, key opinion leaders, or we have board members who are saying, hey, we're just about to get FDA approval. What are we going to do about reimbursement? Well, I hadn't thought about that. Well, what evidence do you have to demonstrate that we're cost effective, that we improve quality of life? Well, I haven't planned for that. Okay, then you're in trouble. You don't want to have to go back and do that. You want to really bake those things in as you're developing your clinical plans. And I've had some people tell me, oh, that's too early. I'm preclinical right now, or we're doing in vitro work. And you got to start thinking about that. Investors are going to want to know that you don't have to have your reimbursement or even your evidence development plan completely determined. But even if you just say, well, we know that we need to develop evidence and we are considering our reimbursement plan. It may be as simple as that, depending on how far along you are. So let's talk about the US healthcare system. Unfortunately, and this is a little bit old, it only goes up to 2015, but it hasn't changed. Unfortunately, the x-axis is health expenditure, the y-axis is life expectancy, and the US is horrible. Even if you consider our neighbor to the north, Canada, has much less health expenditure per patient, per person, and at least as good health outcomes, if not better. We are horrible in terms of other developed nations, but even less developed nations. Mexico, Chile, maybe Hungary, the life expectancy is better, the health outcomes are not as good, and we're spending a lot of money. This will only get worse as the population ages. And people have come to realize that this current growth of cost is unsustainable. People have been talking about this for many years now. So some of the areas that people have discussed are maybe, and this was in the previous administration, luckily not now, repealing the Affordable Care Act, known as the ACA, to try to reduce federal Medicaid spend, to develop progressive payment models to better align reimbursement to patient outcomes. And an example of that would be an accountable care organization, or ACO. We're going to be talking about ACOs a little bit later. Luckily for me, increased focus by payers on health economics and cost effectiveness, and then also various proposals to reduce drug spend, including right now, allowing Medicare to negotiate drug prices. So all of these are not new, and they're still being discussed. We talked a little bit about payers and payers that are going to hopefully reimburse your technology, but who are these payers? 49% are employers, so employer-based insurance. health insurance. We've had that since World War II, when employers were trying to bring their employees back into the fold, and they thought, well, as a perk, let's offer health insurance. The problem with that is that since so much of our health insurance is employer-based, we lose it. If we lose our job, if we change jobs, we may lose it. If the employer decides to change health insurers, so that's a problem from an employer-based insurance standpoint. And then Medicare and Medicaid are also two big payers of interest. So let's talk about Medicare, Medicaid, and commercial insurance. Medicare, as I'm sure you know, is the federal health insurance program for quote unquote the elderly. Now, the elderly is, as far as I'm concerned, 10 years older than my current age. But the definition is for people 65 and older, certain people with disabilities, and importantly, covers patients with end-stage renal disease. Medicare has 4 parts. Part A is inpatient insurance, hospital insurance. Part B, medical insurance, outpatient primarily. Part C, Medicare Advantage, which basically is Medicare managed care. And if you've watched any TV, especially over the last couple of years, you hear these elderly stars, Robert Wagner, Tom Selleck, to name, I think William Shatner probably is in there too, hawking Medicare Advantage plans. There are some advantages to Medicare Advantage. They often include things that would typically be out of pocket in a traditional Medicare plan, such as vision care, dental, maybe even rides to doctor visits. What they don't tell you, and I think there really should be full disclosure here, is that if you have a chronic condition, and a lot of elderly patients do, and you rely on certain providers, if your health plan drops those providers, you're out of luck. You have to find a new provider within that health plan, or you have to find a new health plan. And if you want to go back, if you want to leave Medicare Advantage and go back to traditional Medicare, it's not so easy often. So even though my mother, every day she watches CNN and says, I keep hearing about this Medicare Advantage, should I be doing that? No, absolutely not. You have some pre-existing conditions. You like your providers, you're well controlled, stay with what you've got. You can see here that the majority of patients still have regular traditional fee-for-service, that's what FFS stands for, fee-for-service Medicare, that's 61%, and the others have Medicare Advantage. Again, if you're a relatively healthy person, reasonably healthy person, Medicare Advantage can save you money. It's growing in popularity because it also generally saves the healthcare system money, but not always. Medicare started actually in 1965, and one of the key provisions that was added in 2006, which was really helpful, was Part D, which is prescription drug coverage. Medicare currently insures more than 62 million Americans. That's about 20% of the, I just checked the census to make sure I'm still right. It's about 330 million Americans in the United States. And we already talked about how the covered lives can be segmented into fee-for-service and Medicare Advantage. There are also, so Medicare has well, USCMS, so Centers for Medicare and Medicaid Services, uses what are called MACs, Medicare Administrative Contractors, to process claims, define parameters for coverage, and set payment rates in the United States. These payment rates are subject to coverage determinations. There are national coverage determinations, NCDs, which you think, oh, I want my technology to be under an NCD. I don't want to have to go to these little localities to get covered. The problem with trying to get a national coverage determination is if you're turned down or you get a coverage determination at a reimbursement rate that's lower than what you were hoping for, you're kind of messed up with then having to go back and try to get local coverage determinations from certain MACs that do this, that actually do reimbursement coding. And not all of the Medicare administrative contractors or MACs determine reimbursement codes. So you have to be very careful if you're going for a national coverage code or a local code. So we talked about Part A and Part B of Medicare, and Part A again is hospital or inpatient, Part B is outpatient. And the Medicare Part A/B landscape currently consists of 8 MACs. So again, these administrative contractors that cover 12 jurisdictions. And we discussed the fact that these MACs are responsible for processing claims for Medicare fee-for-service beneficiaries. Here's where it gets even more complicated. You think, okay, you go to these MACs and you get a coverage determination and then they process claims. Now, it depends what your technology is. So for molecular diagnostics, known as MoIDx, there are some of the MACs are the same, but many are different. One of the key Medicare administrative contractors, again, or MACs, I don't want you to think of Big Mac, I want you to think of Medicare here, is Palmetto. Palmetto is located in this region. And you think, well, that's, geographically kind of a small region, except that it has outsized influence versus some of the other MACs. And really all of the other MACs tend to follow Palmetto's coverage decisions. So it's really important to get a positive coverage decision with Palmetto because the others will typically fall in line. Again, to make matters even more complicated, if you have what's called DME POS, durable medical equipment, prosthetics, orthotics, and supply, you've got different MACs. So there are 2 MACs that cover 4 jurisdictions within the US. All right, so that's Medicare in a nutshell. We'll return to that, but let's talk about Medicaid. So Medicare, again, is federally funded, and it's funded by payroll taxes and other types of mechanisms. Medicaid is jointly funded by the federal government and the individual states. And therein lies the problem. Every state has a different flavor of Medicaid. Medicaid is for low-income adults, children, pregnant women, and some people who aren't fully covered under Medicare may be dually eligible to be under Medicaid. So they have both Medicare typically as primary coverage and Medicaid as secondary coverage. As I said, each individual state manages their own Medicaid program. So there are a list of about 15 or so general items that need to be covered under Medicare. But the Affordable Care Act allowed individual states the option of whether or not to expand Medicaid to individuals up to 133% below the FPL and eliminated pre-existing categories one had to fall under to qualify. 30 states chose to expand Medicaid, adding 17 million previously uninsured Americans to the program. I gotta say, I'm a big fan of ACA, no matter what your politics are. We went from 40% uninsured to 10% uninsured in this country with the expansion of ACA. So it really was a boon. In a developed country like the US, I find that it's a travesty to have uninsured people. 20 states chose not to expand Medicaid due to various budgetary concerns. As of April 2021, more than 80 million people, so remember, out of the 330 million in the US, are covered by Medicaid. 4 years prior, only 69 million were covered, right? We've got about 80 million. Prior, it was 69 million. And what do you think that was the main driver for Medicaid coverage over that time period? Something that's been happening over the last 2 years, the pandemic. A lot of people lost jobs, a lot of people lost any kind of coverage and turned to Medicaid to be covered as a result. Before the ACA, the federal government shared Medicaid costs with individual states, with the government paying 57% of the total amount. then that went to 100%, and then now, as of 2020 and going forward, the federal government covers 90% of costs for Medicaid. So we've talked a lot about the commercial market, and that's segmented as well. Blue Cross Blue Shield, or the Blues as we call it, even though this shows 48%, the Blues are very influential. They are the ones that, some of the ones that require the highest amount of evidence to ensure coverage and reimbursement of new technologies. Then you've got about a 50-50 split of regional and national plans, and about 63% of health plans are self-funded by employers. Self-insured employers take risk, and they distribute that amongst their employees, but they sometimes, if they are self-funded, employers find that they can control costs and control patient outcomes better than if they just go with a plan or two. They may negotiate directly with hospitals, for example, or hospital systems. One of the things I normally suggest people do, if you're interested to see what kind of coverage you would expect with your technology, is to conduct what's called a commercial coverage landscape analysis of the top 25 payers by commercial covered lives. So if you see, here are the players. There's a lot of blues, BCBS, BCBS, all the way down here. And some of the top ones that you'll be familiar with: United Healthcare, Anthem, which is a blue, Blue Cross Blue Shield, Aetna, Cigna, Kaiser, and then a lot of the blues. And you can see most of these plans are nationwide. Some are regional. As we said, there's about a 50-50 split. But if you do a landscape review of these top 25, that encompasses 85% of all commercial covered lives, 91 and 77% of Blue Cross Blue Shield and non-Blue Cross Blue Shield commercial covered lives, and then 99 and 68% of national and regional commercial covered lives. Importantly, the national payers and Blue Cross Blue Shield require the highest quality of evidence to qualify for reimbursement and coverage. And to give you an example of how important these coverage policies are, and many of them can be found online. You just Google Blue Cross Blue Shield of Arizona coverage policy for X, and you may very well find it online. And I'll actually show you an example of a coverage policy later. But just to give you an example, my nephew needed a technology that his Blue Cross, his parents' Blue Cross plan considered experimental, that terrible E word, experimental, and they wouldn't cover it, they wouldn't pay for it. So I said to my sister-in-law, well, what do you think I do for a living? Let's look at the evidence. Let's look and see what they require in their coverage policy, and maybe their coverage policy isn't up to date. So the first thing you do is go to treatment guidelines. And they had not referenced the most current treatment guidelines, which were in my nephew's favor. Then I went to the published literature, and I looked to see what the experts, the key opinion leaders or KOLs, were suggesting would be the best types of lab tests to demonstrate positive results with this technology. And I saw that of all the reams of data that we had in all the lab tests, the provider hadn't ordered a couple of the lab tests that, if positive, would be, again, in my nephew's favor in terms of coverage of the technology. So they did she did the lab tests, and one was borderline, but the other was positive. So we put together this confluence of evidence, and the Blue plan reversed their non-coverage policy for them. It saved them a lot of money, it saved them a lot of grief, and it shows you that, unfortunately, it's a little bit of a game. It's a little bit of a chess game with the insurers trying to not cover as much as they can, and you say, no, you need to cover this. So I promised that I would talk about ACOs, accountable care organizations, and this is basically a type of managed care, if you will. But we're looking for improved patient outcomes, so that incentivizes the providers. It's not a traditional fee-for-service model, it's capitated. The majority of providers involved have Medicare patients, and then you have some that have commercial and Medicaid, but more Medicare than not. And you can see here that over the last, even though this is a little bit old, this only goes up to 2016, but there's definitely a trend towards the number of ACOs increasing, and that trend is only going up over time. So the next title here is Regulatory Requirements and Reimbursement. Before we really talk about that, I want to start talking a little bit about coding, reimbursement codes. So let's use as an example, durable medical equipment. DME that Medicare covers it's not limited to this, but blood sugar monitors, canes, hospital beds, wheelchairs, walkers, etc. It also includes prosthetics, orthotics, and supplies. But it depends what you're specifically covering in the DME POS in terms of what kind of coding, reimbursement coding you could expect, and what kind of fee schedule this is under. So for example, for durable medical equipment, there's what's called a HCPCS code, and we'll talk about the different codes in a second. But here it's an HCPCS E code. For prosthetics and orthotics, use HCPCS L code. By the way, please don't say HCPCS. There's no S here. I hear people say that, it drives me nuts. It's HCPCS. Might be a mouthful, but you get used to it. L codes. And then for supplies, they are reimbursed under HCPCS A codes. And this we really talked about already, fee schedule, so we'll skip that. Now, I mentioned that in general, the Medicare administrative contractors, or the MACs, process claims. But there are a couple, Noridian is one, but Palmetto, that all-important Palmetto, actually does coding verification. And that's the process whereby you request a coding decision that gives you your reimbursement amount. I'm actually consulting to a South Korean company that is hoping to get reimbursement code in the US. And they used, ironically, a large Korean pharmaceutical company that had a small outlet in the US who said, we can get your reimbursement code, no problem. Well, they did, but they got them a supply reimbursement code. This was under DME POS. They got them a supply code instead of an orthotics code. And it's about a third, at about a third of the amount that they were looking for. So we're redoing this. You also have a limited amount of time to contest the code that the MAC awards you. And they went past the code, I think, because the company that helped them was embarrassed that they didn't get the code that they were looking for. So they went beyond that. So we've got to start the process all over again. We've since resubmitted with much more evidence. You really have to look at what code you want. What is the description of the code? I mean, it's pretty straightforward. And make sure you meet that description at every single step. And don't meet the description of the reimbursement codes that are at a lower level. So here's where we get to the promised regulatory pathway. The idea being that it's not the center that you go through that's important. It's the regulatory pathway and the ruling that's important. Whether you have de novo or breakthrough designation will make a big difference, not only in your possible reimbursement, but in the investors and how interested they are in you. So for example, if you have a combination product, such as a visco supplement for knee osteoarthritis, that may be considered a combination of device and drug, And rather than going through the regulatory pathway through CDRH, Center for Devices and Radiological Health, you may be relegated to CBER, Center for Biologics Evaluation and Research. That's not as important as what your designation is. So we've been talking about reimbursement codes, and like it or not, I'm going to get into the depth of reimbursement codes. It's a little scary, but I'll go through it. I'll try to go through it slowly. You're probably most familiar with CPT codes because you see these on your own reimbursement, your own insurance claims. CPT stands for current procedural terminology. They're typically 5-digit numeric codes. They're administered by the AMA, and they're all settings of care. Setting of care is important because that helps to determine which code is used for reimbursement. Now here's the HCPCS code. Healthcare Common Procedure Coding System is what HCPCS stands for. These are alphanumeric codes, and so they typically start with a letter and then followed by 4 digits. These are administered by CMS, and again, they're in all settings of care: physician office, inpatient, outpatient, ambulatory surgical center, etc. Then you have diagnosis codes. I typically think of these as disease codes, but they don't have to be. They're inpatient only, but you can have ICD-9 or ICD-10, or now, unfortunately, as of January, ICD-11 codes that can be procedure codes, as well as being diagnosis codes. The ICD-9s were administered by NCHS, National Center for Health Statistics, and CMS, but going forward, ICD-10 and then now 11 are being administered by CDC. HCPCS codes are segmented into 2 categories: level 1, which are the actual CPT codes, and level 2, which is everything else: the DME PAS, product supplies, etc. And to make this even more confusing, if you will, you have 3 categories of CPT codes. So here you had HCPCS, level 1 was CPT. Out of the CPT, you have 3 categories. You want category 1 because that's the one that's likely to be reimbursed. Category 2 is really just supplemental to that because it's updated. It's category 1 that's updated 3 times a year. Category 3 is the all-concerning experimental. You might be relegated to category 3 until you have adequate evidence to be able to apply for category 1. And sometimes it takes several years to go from 3 to 1. So you want to make sure that you've looked to see what evidence is necessary for your technology to qualify for a category 1 code. If there's a predicate, so there's something that's similar to what you've got, your technology, then you should be able to get a category 1 code. Maybe you're getting a category 1 code and you're thinking, well, I'll apply for a new code at some point. That might be something that you want to do as we develop new evidence that will allow us to have a higher reimbursement. This isn't so important offhand, and we're going to be talking about fee schedules. So I'll somewhat skip this slide. Outside of the United States, it's pretty straightforward. You have generally nationalized health systems, as you know, and you have fee schedules that cover everything. But as you've seen, not so here. There are some fee schedules, however, but payments in general are modified by setting of care and what actual services are being provided. So you have physician services that are typically fee for service, coded by CPT codes, and there are fee schedules. In this case, there's a Medicare physician fee schedule that gives you an outline of, for example, there's usually a 99 followed by 3-digit codes for an office visit. And then depending on the how difficult that office visit is, it might be supplemented by other codes. Then you have inpatient hospital and outpatient hospital, different payment mechanisms, different coding, and different fee schedules, if there is a fee schedule. The difference between ICD-9 and ICD-10 and beyond is that now in ICD-10, first of all, the number of codes, disease classification codes or diagnosis classification codes has ballooned, with the idea that you have more granularity. It also takes into consideration now disease severity. So that's a good thing, but it makes the coding that much more difficult. And what I found in my research and what others have also found is that because we're generally, when I do this type of research, I'm using claims data. You probably got about 10% of codes that are incorrect. It might be intentional. There may be upcoding, people trying to get greater reimbursement than a baseline code, or it may be unintentional, especially with this ballooning of codes. But you can expect that at least 10% are going to be incorrect. That wreaks havoc with my research, but you hope that the majority of the codes will be correct. And you look for other things such as medications or other things that will, other variables that will help you determine that this patient actually has this disease or condition of interest. Here you've got the DME POS that we talked about, and then laboratory diagnostics have their own fee schedule. So what happens with all of these different reimbursement components, and how do they converge to create this coverage, coding, and payment that we've been talking about? You have national and state legislation that influences payer benefit design. And maybe one of the types of payer benefits that you've experienced or which you may be most familiar would be tiers, that is TIERS, maybe it's tiers also, for medications. So tier 1 would typically be generic drugs and would be not require a copay. Tier 2 might be a branded generic, so maybe there's a $10 copay. Tier 3 may be a lower cost brand name drug. Tier 4 may be a higher cost brand name drug. And Tier 5 might be a specialty medication for patients with certain chronic conditions. Payer benefit design then influences coding, coverage policy, and payment, all of which will influence your clinical positioning, should help you to determine what your value proposition should be, and also help you determine what evidence you need to support your value proposition. There's another term that people might not be familiar with that's more important in the diagnostic and device world than it is in the drug world, called clinical utility. And basically what clinical utility is and how this influences reimbursement is what is the probability that a clinician will change the way they're treating a patient based on the outcomes of your test, and what is the probability that the patient will have better outcomes as a result of your test or your device. So some of the patient outcomes that could be examined, and you don't have to examine this right away using an RCT or an observational study. You can start out just doing a physician or clinician survey to say, okay, if you use our diagnostic test or device, how do you think that patients will do in terms of hospital readmission, length of stay, functional outcomes such as activities of daily living and patient quality of life, and then patient burden, risk, or cost. What do you expect that they'll have the same or better outcomes as a result of the availability of your test or device? The all-important coverage, coding, and payment. So we've talked about this, we've talked a little bit about the confluence of these, but basically for coverage, does the technology improve patient outcomes? For coding, are the specific codes for physicians and hospitals that accurately describe the service, and then payment. Do third-party payers provide competitive reimbursement that supports the manufacturer's price of the product? Something I wanted to read you that I thought was very topical and was a published blog from an Annals of Internal Medicine article from 2 days ago. And it's a physician that states, I spent my lunch break going to a coding session. It was the adult physician equivalent of a timeout. The coders explained to me that if my clinic encounter didn't match up with the current financial identification number, my encounter could not be appropriately billed and therefore, quote, didn't count. I could only say that during the meeting, my soul left my body for a brief moment, wondering, even if we code everything perfectly, how much does our work really count? So I felt kind of bad for this provider, but it just goes to show that coverage coding and payment really makes the world go round. And if you don't take anything else out of this talk, if you see the second bullet, because I'm not sure if you can actually see my mouse, first and foremost, establishing payer coverage is vital to a successful reimbursement strategy. Please never say to me or anybody else that's talking to you about reimbursement or evidence development, oh, I'm really early stage, I don't have to worry about that. Okay, yes, you do. And your investors are going to worry about that. You have to start thinking about it very early in the course of your technology development. So as I mentioned, there are multiple factors that determine whether a payer will provide coverage for a different technology. Some carry more weight than others. And unfortunately, if you're hearing drilling, they're drilling above me, and I figured during lunch, they wouldn't be drilling, but they are. So please excuse that. Anyway, the first thing is to determine unmet need, and we talked about that. If you're lucky, it's already been done for you, and you can just grab the peer-reviewed clinical literature. We mentioned professional society guidelines and how important those are. Independent technology assessments. I mentioned physician and KOL demand and how important that can be in adoption of a new technology. And of course, everything is political, especially, I guess, in healthcare. Payer group, patient groups, and clinician groups can actually be very influential in reversing a negative coverage decision. So I promised you that I would show you what a coverage policy looks like. You can't possibly read this, but it's Anthem Blue Cross Blue Shield. And basically what this demonstrates is which products and indications are considered medically necessary or not. What are the utilization restrictions, such as step therapy or prior auth? And they'll provide a position statement rationale, which often has citations associated with it. So some of those citations would be evidence that I've published or that others have published that now the payer, the insurer, is citing in support of their position. There are several triggers that could cause payers to develop a new coverage policy, such as high procedure volume, high treatment cost per patient, high demand for the procedure, and concerns over safety and/or efficacy. Of course, the top three are cost to the health plan. That's what they're worried about. And these coverage policies are typically updated on an annual basis, but you can't be sure that all of the latest information, as I mentioned to you, is included in the coverage policy. The coverage that you can find, as I said, most of it you can just Google. It may be explicit, it may be silent, so it may be conferred on a case-by-case basis as to what happened with my nephew. It may be implicit non-coverage, so it doesn't say it's not covered, but it doesn't say, but since it doesn't say it's covered, it may be non-covered, part of the tricks here. And then it may be explicit non-coverage. And I've been mentioning costs associated with Medicare, Medicaid, and commercial payers. And Kaiser Family Foundation recently did a study where they demonstrated that private payer payment rates averaged about 1.5 times Medicare rates overall. So if you're doing a study or you're doing an analysis and all you have is Medicare data, for example, or all you have is Medicaid, or all you have is commercial, you can infer what those costs might be for the other two. So since commercial is about 1.5 times Medicare, in contrast, Medicaid payment rates have stayed relatively constant at 70 to 90% that of Medicare. And lastly, I threw this in because we've all been affected, I would say positively, by telehealth and telemedicine. And somebody asked me to specifically talk about in one of my other discussions about telehealth coverage. And you can see that you have CPT and HCPCS codes, because now you know all about those, and that these cover Medicare visits, they cover virtual check-in, they cover e-visits, and of all the horrible negative things that have happened to us because of the pandemic, I think this has been a positive. The pandemic has really rocketed telehealth into our vernacular, into everyday life. And I think that is really a positive. It helps seniors that can't get out. It helps people in our remote areas. And I think we find that we can do, well, in general in life, we find that we can do a lot more remotely than we expected. And so hopefully that this gave you a general overview of coverage coding and payment, what reimbursement is all about in the US, and how evidence development informs reimbursement. Thanks for your attention.
Excellent. Thank you so much, Renee. That was a really wonderful webinar. Patrick, I'm wondering if you would like to moderate the Q&A.
Sure. I did see a few questions come in. So first one here, will Part D cover the emerging category of digital therapeutics?
Oh my, good question. There's no coverage policy on that yet, so we don't know. The FDA, as you know, is still trying to determine if these are going to be, if you're going to require FDA approval for some of the digital therapeutics. A lot of them are starting to need evidence development and specific FDA approval. And so I think Medicare is going to wait and see on many of these.
Okay, next question. Do commercial payers or employers each have their own reimbursement coding system, or do they generally adhere to the CPT HCPCS coding?
They adhere to that coding. So that's the idea of the codes, even though it's confusing and there's a lot of different codes, everybody uses the same coding systems. They just really use them a little bit differently, or apply them a little bit differently. But yes, they all use the same systems. So you're not going to see different CPT codes. If it's 999347, it's quote unquote, it's an office visit, regardless of where you are.
Okay, another question here in the chat. How do you search for usage frequency of reimbursement codes to better understand disease prevalence?
Say that one again, please.
How do you search for usage frequency of reimbursement codes such as CPT, ICD-10, HCPCS codes to better understand disease prevalence?
Unfortunately, if you end up doing that landscape coverage evaluation, you end up having to go to the individual plans. And so it's a good idea to start out with the plans that have the largest number of covered lives. You go to, let's say, Blue Cross Blue Shield of California. They actually have an online service that it's called Evidence Report, something like that. United Healthcare, as you saw in that listing, and that will give you an indication by those largest number of commercial insurers what the coverage policies are by disease category.
Okay. What are some special reimbursement or economics considerations for software as a medical device, or SAMD?
Well, again, these are new, right? It used to be not too long ago that software did not require FDA approval. Now, a lot of it does require FDA approval. The more approval that's required, the more evidence development is necessary. And so I just go back to evidence, evidence, evidence. That is the most important. You want the highest quality evidence you can get. I've been talking with one NHLBI awardee about doing an observational study. So a pragmatic clinical trial. It doesn't have to necessarily be an RCT. As a matter of fact, a lot of insurers now are interested in RWE, real world evidence, where you randomize patients, as you know, to your technology and let's say nothing or another standard of care, and then let it run so that you don't have protocol induced costs. And this gives you a better idea often of what the true cost of an episode of care is with and without your technology.
Okay. Next question. In making the case for efficacy and clinical utility, how much leverage does the FDA approval package usually provide? Where is it more or less impactful?
Unfortunately, the FDA approval package doesn't often say a lot about clinical utility. And that's why I said it's really about canvassing health professionals and asking them, how would this impact it? Because it's more reimbursement, and the FDA doesn't have anything to do with reimbursement. Unlike in other countries where you have some explicit ways of going about developing reimbursement based on your technology and based on your evidence, you kind of don't have that here. And that's why you end up doing all this extra work, looking up all the health plans coverage policies and that type of thing. So I would say that the FDA package really doesn't provide a lot in terms of clinical utility. And that's why I've been telling some of our awardees about clinical utility and how important that is towards reimbursement.
Okay. Can you give an update on the coverage of liquid biopsy tests?
Oh my. You know, we were just talking about that the other day, and there's not yet, to my knowledge, and I'm not the most up to date on this, been a coverage determination on that, but we're definitely going in that direction because it can be less expensive. But then you're talking about, is it for a specific disease? Is it for a plethora, such as GRAIL, where you're looking for a bunch of different kinds of cancer, or is it just one cancer? And it really depends on, again, what the specificity and sensitivity is of the test in an individual cancer versus this plethora and the ability to really distinguish. Plus, as we know now, mutations aren't necessarily organ specific. They may be a mutation that's across organs, and that's maybe what's causing, you know, the metastasis of the cancer. So that it's really a moving target, and it depends on if it's just one cancer or if it's trying to distinguish amongst many.
Okay, and one more question I see in the chat here. Where do you see addiction services in this ecosystem as it relates to non-clinical or early intervention recovery, supportive delivery, and digital therapeutics?
I would say that, especially with this opioid crisis, and IMH, I know is really very focused, as you can imagine, on this, with telehealth services, with the confluence of all these remote services, and with the understanding of how prevalent addiction is and how early intervention can make a big difference on downstream costs. I would say that it's going to go towards more coverage of these services. That said, unfortunately, the US has not been the best in terms of preventive services. That's what HMOs are supposed to be, but it's more disease maintenance than it is health maintenance. I think we're going to start going more towards health prevention because it's better to pay up front than to pay much more downstream.
Okay, thank you everyone for that Q&A session. So at this time, I'm going to go ahead and launch the evaluation poll. So please do take a brief moment to provide your feedback. Also, I'm going to turn it over now to Marissa, who's going to provide some information about some upcoming webinars. Marissa?
Fantastic. Thank you again, Renee, and thank you so much, Patrick. While you are filling out that poll, I'd like to make you aware of a few important upcoming events. As many of you already know, the new funding opportunities for the Catalyze program have been announced, and applications for non-AIDS related projects are due March 21st. And likewise, applications for AIDS related projects are due April 18th. Additional details about the RFA specifically can be found on our website, NHLBI Catalyze.org, which I will drop in the chat momentarily. There you go. And to assist with application completion, Dr. Mike Peck, the Scientific Director of Catalyze, has pre-recorded a webinar about project definition, which will be available on the FAQ page of that same website. It dropped in the chat. Next Friday, February 25th, Dr. Peck will be hosting the first of 2 application office hours where your application-related questions are welcomed. The next office hour opportunity is offered on Thursday, March 10th. And again, Zoom links will be available shortly on the FAQ page of our website as well. We also have our next seminar scheduled on Friday, March 11th, which will be presented by Kwame Ulmer, and will walk you through approaching the FDA as a MedTech innovator. The link to register for that webinar can be found on the events page of our website. And finally, you can stay up to date on all of these activities and more by signing up for our email listserv. And you can submit your preferred email address right on the home page of our website. Again, that's dropped in the chat. And with that, thank you, everyone. We are right at the top of the hour. So thank you again for your attention and coming, and we'll see you at our next event.